Now, after a lot of wait, we are moving on to the last, and probably everybody is looking forward towards this last presentation. This presentation will be taken by Dr. Varesh Nagrath sir, and I invite our Professor Dr. Rajkishore Singh sir, Professor of Medicine at BRD Medical College, who's been doing exemplary work at BRD Medical College, to please chair the session.
Attention please. Now we are going to start a very wonderful topic, very practical topic, how to make differential diagnosis if a patient with confirmed hyperglycemia presents to you. By a very learned orator and my senior, my guru, Dr. Varesh Nagrath sir. Really I am feeling blessed and very much honored to introduce him here. Varesh sir, please.
Okay.
Please start your.
Okay. Thanks to the organizers for giving me this opportunity. Special thank to the doctors who are still sitting only to motivate us, and more special thanks to the doctors who are eating, that they have not left for their home. So I am really grateful. So diabetes, is it only type 1 and type 2, or there are other type of diabetes as well? And how important is it to know what type of diabetes is it? A disclosure that many of the slides I have taken from the PHFI course, so I have taken permission from them also. So this will be the flow of my presentation. How do we define diabetes? So if symptoms of diabetes are there and random plasma glucose is more than 200, we will label the patient as diabetic. Fasting more than 125, 2 RPP more than 200, A1C more than equal to 6.5. So this is the definition of pre-diabetes. And now this is my question. Plasma glucose at 0 minute 120, PP 209, will we call this patient a diabetic or not? Yes, we will call it, because PP is more than 200. Another patient, fasting 96, PP 186. Is it normal or is it pre-diabetes? It's pre-diabetes, very good. So classification broadly, type 2 diabetes, type 1 diabetes, Lada, Modi, GDM. These are the common subsets. And the biggest dilemma is in youth and young adults, where the differential diagnosis is type 1 diabetes, monogenic diabetes, type 2 and secondary diabetes. Type 1 patients have total destruction of beta cell. They are totally dependent on exogenous insulin. It's not very common. Onset is usually in childhood and adolescence, but a variant of type 1 diabetes can present in adults also, which is known as Lada. There is abrupt onset, may present with diabetes ketoacidosis, and they have lean body mass. A1C is very high, urine may be positive for ketones, C-peptide is low, anti-GAD antibodies are positive. Type 2 diabetes, which is bread and butter for us, it's alarming pace, it's increasing in all age groups. It's most common. There is a strong family history, and both the sides, the maternal as well as the paternal sides, they can be affected. And the hallmark of type 2 diabetes is the stigma of insulin resistance. We need to document some stigma of insulin resistance before labeling a patient as type 2 diabetes. And what are the stigmas? It's visceral obesity, acanthosis nigricans, skin tags, especially in the neck and the axilla. So examining the neck, and if it's clear, then examining the axilla is very important for establishing the diagnosis of type 2 diabetes. Also, if fatty liver is there, PCOD is there, they are also corroborative. There is fair beta cell reserve. So these are the skin tags, and acanthosis nigricans in the axilla and that in the neck. Now we come to monogenic diabetes. There is mutation in a single gene. Age of onset is less than 25. They are non-obese, autosomal dominant, and family history, either the maternal or the paternal side, should be affected. Diabetes should be documented in 3 generations, and onset of diabetes in the family members should be less than 25 years of age. They have usually normal body weight. They are initially SU responders. Hallmarks of insulin resistance are absent, and ketosis also is not seen. Later, many of them require insulin. Genetic testing is needed to confirm the diagnosis. Now, fibrocalculous pancreatic diabetes, which we thought happens only in Kerala, but that's not true. Dr. Raj Kishore has a series of FCPD patients which he has diagnosed here in Gorakhpur. So we should also keep in mind that FCPD, fibrocalculous pancreatic diabetes, can also present. And how do they present? They present with pain abdomen. A child with diabetes with pain abdomen, pain increases PP, and we get an ultrasound done. Ultrasound shows shrunken pancreas, calcifications in the pancreatic duct, recurrent abdominal pain, steatorrhea. So these are the pointers of FCPD, and if we get a plain X-ray done, there also calcification can be seen. So if a young patient or a child presents with diabetes and pain abdomen, then FCPD also has to be considered. Now Lada, what is Lada? Latent autoimmune diabetes of adults. It is type 1 diabetes which presents late. It's called 1.5 diabetes also. It's immune mediated. At least one autoantibody is present. Age should be more than 30 years. Eventually they require insulin. G-peptide is low. C-peptide is low. GDM, gestational diabetes, we will label only if 24 weeks have passed. Before 24 weeks, it is not GDM. It is diabetes with pregnancy. So fasting more than 92, 1 RPP more than 180, and 2 RPP more than 153, we diagnose GDM. Now these are few questions. A 9-year boy presents to us with complaints of polyuria, polydipsia, polyphagia, tiredness, and abdominal pain. Fasting very high, HbA1c very high, C-peptide low. What are the possibilities? What are the possibilities? FCPD, but yes, very true. So the possibility will be either type 1 diabetes or FCPD. So whenever pain abdomen is there in a diabetic, we must think about pancreas. That should immediately click our mind. Second question, 20-year girl, fasting 196, PP 320, A1C 9.8. She has a strong family history of diabetes. BMI is high, 26, and acanthosis nigricans and skin tags are there. So to which group will this fall? So this is clear-cut type 2. There is no rocket of science in this. Another case. Yes. This is an 18-year girl presents to OPD with complaints of recurrent boils on the back. Fasting 205, PP 321, A1C 9.9, BMI 24. She has a strong family history of diabetes, and all the family members had onset of disease after 40 years of age. 45 years of age. Is monogenic diabetes a possibility or not? Yes. It is not a possibility. In order to say label a person as monogenic diabetes, the onset of disease in the family members also should be less than 25 years. A 4-month pregnancy, fasting 130, PP 220, A1C 8.8. Is GDM present or not? So GDM is not there. It is diabetes with pregnancy. 55-year male, not controlled on triple drug, fasting 250, PP 350, high A1C of 9.5, BMI low, 18.5. No evidence of acanthosis nigricans or skin tag. What is the diagnosis? It's Lada, very good. So it's Lada. So that completes my talk. The key takeaways are type 2 diabetes is the commonest type of diabetes. Family history we should take in each and every patient. BMI we should measure in each and every patient. Examination of skin tags and acanthosis nigricans is we should search thoroughly for this, and variant of type 1 diabetes can present in adults also. Thanks a lot for being there.
Thanks, sir. Thanks. Thanks a lot for presenting such a complicated topic in very simple way. Is there any question?
Tell me.
Dr. Varesh,
Ji, boss.
question. Whether the insulin antibody has clinical significance in differentiating type 1 from type 2? If so, are we using it in our practice? इंसुलिन एंटीबॉडी उसका क्या हम इस्तेमाल कर रहे हैं डिफरेंशिएशन के लिए?
देखिए पहले तो GAD 65 कराएंगे. If the patient can afford GAD 65, then we will get anti-islet cell and insulin antibodies also. These antibodies only prove that the etiology is immune mediated. Type 1 diabetes can be immune mediated, it can be non-immune mediated also. So if these autoantibodies are present in type 1 diabetes, this means this is an immune mediated type of type 1 diabetes. In Lada also, we will get these antibodies, any of these three positive. In Lada we can get this, but we will get it in initial 6 months only, right?